So this was a study that showed that if you could defibrillate someone within 8 minutes, their chances of survival increased 43%, as long as that person also received CPR within 5 minutes. So CPR within 5 minutes, defibrillation within 8 minutes, 43% increase in out-of-hospital cardiac arrest survival. Does anybody know what year this study was done? Give you some hints. Pinto was the best-selling car that year. Jimmy Carter was president. Salem's Lot was the highest-grossing. Chic's Good Times was the best-selling Motown song. Arthur Ashe won Wimbledon. Yes, it was 1979. We are clinging to this study in system design, and we have built EMS systems around an 8-minute standard where, as you've heard today, anyone can defibrillate. And remember, that study said CPR within 5 minutes, along with defibrillation within 8 minutes. How many people in the room can, with 90% assurance, say that their EMS system puts a trained chest compressor at patient side within 5 minutes with 90% reliability? But that's the most important metric. Why aren't we doing that? Why aren't we tracking that? We tend to focus on this 8-minute, 9-minute, 10-minute ambulance response time, where for 95% of the calls, it doesn't matter. But for 5% of the calls, we gotta have somebody there within 5 minutes. There are systems that we've recently reviewed, and you saw Joni put up, I think it was Joni, or maybe Dr. Bronsky, put up call processing times and how long it takes to process a call, and some discussion about processing a call takes a little bit longer when you're doing emergency medical dispatch. Many systems have found when they start using a structured emergency dispatch process, forget just medical, PD and fire as well, their call processing time goes down. And if you were to objectively look at your call processing time, you would be shocked at what the data will show you. Just finished an analysis that we're presenting to the 911 board in a county on the east side of the country tomorrow morning to show them that the data they've been reporting to the community of an average 35-second call processing time is wrong. It is not true. Because from the time that the phone is answered, 911, what's the address of your emergency, to the time that the first fire unit is notified to respond to the call, on average, 1 minute, 36 seconds. With a 90% reliability factor, it's almost 2 minutes. So this thought of call processing times, very important when you talk about response times for 5% of our call volume. But yet, from the time we can get somebody to put hands on the chest during the call taking process is important. I'm going to show these on the screen. We're not going to talk about them, but these are all the studies that have shown there is virtually no correlation. Medical, trauma, major trauma, penetrating, cardiac arrest, whatever it is, that basically says if you're not going to get there within 5 minutes, it doesn't matter when you get there in terms of patient outcome. Don't take our word for it, peer-reviewed studies. This is from a study that was done in Fort Worth this year, and the Fort Worth City Council was told that all of the research, this was a different consulting group than the one I currently represent. They said that all of the research coalesces around the fact that a 5-minute response time is the only response time that matters in 5% of the call volume. And any response time guideline that you set greater than 5 minutes is a public policy decision. It is not a clinical decision. Because faster response times for 95% of the call volume does not equate to changes in patient outcome. Dr. Kupis already talked about this one, but we put the link in there for you so you can make sure that you can find it electronically. The thing that I want to mention about this is that both position statements that Dr. Kupis talked about earlier today These are associations that ordinarily cannot agree on the color of the sky. But yet, they all agreed that red light and siren responses are bad and should be reduced to just the bare minimum number of calls where response time and the risk of a light and siren response outweighs the benefit, and that the metrics that we should be tracking should de-emphasize response time as a performance metric. When I first got to MedStar, Dr. Beeson, Jeff Beeson was our medical director, and we even implemented a policy. If you're going to do CPR in the back of the ambulance on the way to the hospital, that is a non-light and siren transport. Because you can do better CPR when you're not weaving in and out of traffic. Quite frankly, it's safer for the crew in the back of the truck because they're not getting jostled around, because how many people go into 4-point restraints when they're doing CPR in the back of the truck, right? Thankfully, in many cases now we're using MCDs and whatnot. And also the time saved that we found doing our own time study, hot transport versus cold transport, was 1:37 seconds. And on average, it took 3.5 minutes from the time the ambulance was put in park in the emergency room to the time the patient came out of the back of the truck. Because they're taking down IVs, they're doing all this different stuff. So we basically said, just plan ahead, do that stuff ahead of time, take your 3 minutes down to 1 minute, and you've saved all that time and you've been much safer. Okay, makes a ton of sense. So where did this all ALS thing come from? Anybody know? I'll tell you that public utility models are to blame. Because Jack Stout and the folks way back in the day when they started putting together systems like MAST, the Metropolitan Ambulance Service Trust, said we can maximize revenue. It's a revenue question. We can maximize revenue by having a paramedic in every truck and billing every call ALS. And that reduces taxpayer burden. Jack Stout, amazing human, know him personally, super guy, very smart. He was an economist, not an EMS guy, he was an economist. And he got this. Also, during that time, he said that the call-taking process in dispatch basically is a crapshoot because nobody's trained in the call centers, and basically we don't know when that call comes in really what's going on. So it's better to have the highest level of care available to go to every call because we have no idea, based on the call-taking process, what's actually going on at the scene. A year after that was done at MAST, this came out. Anybody recognize that process? You've heard about it a couple times already. Today, most reasonable and responsible PSAPs are doing emergency medical dispatch. Now I get, and we have this conversation with communities all across the country, the sheriff's office or whoever is running the PSAP, EMS is 15% of their call volume. And they don't want to mess with this. Well, you got to do what they're doing in Michigan. You got to do what they're doing in other places and really show them the benefits to the customer, which is their taxpayer, for doing emergency medical dispatch. These are some of the studies that have also shown that ALS and BLS have the same outcomes. In fact, in most cases, most studies that have been done, BLS care has better outcomes than ALS care. The one that got the most attention was this study that was done by Harvard and published in JAMA, which is not an easy thing to do. And these researchers looking at Medicare claims data, looking at Medicare patients who had a pre-hospital cardiac arrest, arrived at the hospital. This cohort got BLS care, this cohort got ALS care, which had the highest survival to discharge survival rate. And it was 9% compared to 13%, which had the 9, which had the 13. BLS care, 13% survival rate. ALS care, 9% survival rate. The problem with this study, especially with it being on the front page of the Washington Post, is it started a lot of conversations with Medicare. Why are we paying more for ALS than BLS when BLS care is better for the patient than ALS? It's an interesting conversation. We didn't like those questions, Mark, did we? Those are tough questions to answer. The number of paramedics dramatically impacts their ability to be good paramedics. If you're having a cardiac procedure done, Do you want it done by the cardiologist that does 10 procedures a year or the one that does 10 procedures a week? I would say the same thing about a paramedic. So the paramedic that intubates one patient a quarter is not going to be as good as the paramedic that intubates one patient a shift. Anybody disagree with that? But yet, we have paramedics running in these systems that are way underutilized, and studies that have looked at the correlation between the number of paramedics in the system and the success rate of critical decision-making, skills, procedures, etc., have shown the more paramedics you have, the crappier they are. Every study. But yet, we cling on to this myth that we got to have a paramedic on every call. And the reality is, doing so is hurting people. Love Dr. Peirce. I think, this was one of the tipping points. Back in 2006, USA Today did a series of articles called 6 Minutes to Live or Die in the United States. And their research and their site visits to places like Seattle, Boston, Miami, Fort Lauderdale, Milwaukee, they wrote that the more paramedics that you have in the system, the worse the patient outcomes because of the lack of actual patient care experience that these paramedics are getting. Again, don't take our word for it. The links are here. Read the studies. Don't shoot the messenger. Just giving you the reality of what's befuddling many of our EMS systems. This was a fun study that basically looked at ESO data. 1.7 million patients. What percentage of the patients received a potentially life-saving intervention? Anybody remember this study from 2 months ago? 6% of the patient population received a potentially life-saving intervention. But yet we insist on putting a paramedic on every ambulance. Makes no sense whatsoever. There's the position paper we've talked about. I'm going to blow through that because it already has been covered. That resource document that somebody asked about, we talked about earlier. This is online. I'll make sure that the handout has the link where you can get it. There are literally 4 pages of studies with links talking about response times, lights and siren, all ALS versus tiered response, et cetera, et cetera. So again, our economic challenge, and one of the things that's causing our systems to fail is the economics. Shorter response time is more expensive because you got to have a bunch of units sitting around not doing anything to meet that response time, ALS or BLS. Now, I will argue that the unit hour cost for an ALS unit is not that much different than the unit hour cost perhaps for a BLS unit. However, because of things like needing to have a paramedic in every unit, you're paying a bunch of overtime, you're paying a bunch of incentives to get people to work. That drives up the unit hour cost. So if you didn't have to do that, and we'll show you that example here in just a moment, it matters. And then the deployment model, would anyone disagree that there are more EMS responses at noon than there are at 3 in the morning? Yeah. Any system we've looked at, every system we've looked at, there are more responses at noon than there are at 3 in the morning. If you are staffing the same number of resources at noon than you are at 3 in the morning, the question is, why? Because at noon, you're going to run out of units. At 3 in the morning, you got way too many. It's not a very efficient system. So here's what we're seeing systems doing, looking at this ALS tiered response, changing response time expectations in the community. You heard Dr. Zavadsky talk about what we did when I was at MedStar. This was exactly the same analysis that they did in Colorado Springs. We wanted to reprioritize our system, reduce our light and siren responses, and go to a tiered deployment system. So we looked at all this data, found the same thing that Dr. Zavadsky found, that the vast majority of our calls were not ALS. 40% of our 911 calls received ALS care. Of that 40%, the vast majority were monitor IV. That's not really an intervention. That's more of an ALS, I'm not sure what to do, so as long as I'm here, I might as well do it. But only 20% of the patients had a medication administered. Of that 20%, what was the most common medication administered to that population? Aspirin's a BLS drug. I'm talking about, most common ALS drug. Zofran, right? Probably because of the ambulance ride. So we did two things. One, we made Zofran administration a BLS skill because it's low risk. And the recent study that just came out, 18 months ago, there's a procedure that is far more effective at reducing nausea and vomiting, the administration of Zofran. And what is that procedure? Alcohol prep under the nose. So that became our protocol for nausea and vomiting. What are we doing? So here's a tiered deployment system, and I'll tell you it worked really well, just like Dr. Bronsky. It's currently in place today. In the MedStar system, only 36% of our 911 calls get a hot response. And first response, by the way. It's a whole other discussion we won't get into. Community education was the key. So we did a ton of community education, city councils. If you're in your community, as you heard Dr. Bronsky say, you heard everybody say, this starts as a slow process. Education, your data, because your system is different, right? Every system is unique. But I can almost guarantee you that if you do this same analysis in your system, you will find the same results. We've done it in a dozen communities over the last 6 months. The results are always nearly identical. Fun conversation with the city manager in California 2 months ago. Hey, we can't afford this ALS first response thing. It's killing us. Do we really need a paramedic on our engines? Because the overtime alone is killing us. I said, well, can you ask the EMS chief to send us all of the ALS procedures that were done by the first response unit, and we'll have a look at them. They sent over all their records. 90% of the things that were on that list were epinephrine and atropine. I said, okay, revised data request. Can you send us a list of all the ALS care that was administered prior to the ambulance arriving on the call? 20,000 calls a year. Anybody want to guess how many calls last year that system had an ALS intervention before the ambulance arrived? 0. Even the airway management is an SGA in that system. SGA is a BLS skill. IM epinephrine is a BLS skill. There were a couple of those. But what are we doing? What does the patient expect? This is a great study that we did at the MedStar system. It's now being done nationally thanks to EMS survey team. We looked at all of our responses since we started doing the EMS survey team patient satisfaction survey, which is 2013. We took the answers to the question, the ambulance arrived in a timely manner, which is one of the questions on the EMS survey team database. Not did the ambulance arrive on time, it was, in your opinion, on a scale of 1 to 5, the degree to which the ambulance arrived in a timely manner. We pulled out the answers to those questions for only 911 calls where we were the only responding agency and we responded cold. 10,000 plus calls. And you'll note across the bottom is the response time in seconds, and the scores, patient experience scores on the left axis. Even at 60-minute response times, we were getting 5 out of 5 in patient satisfaction. Because the patient knew they had a low acuity complaint, the fact that somebody came today and gave them a free ride to the emergency room, and the crew was nice, was fine with them. During our processes of notifying and working with all of our city councils, we did a community survey, and this is an example of some of the publications that we did to let people know this, but we did a community survey. Thousands of responses. One of the questions was, do you think, your opinion, that someone who's having a heart attack should have a different type of EMS response than someone who twisted their ankle? And what do you think the community said? Yeah. That makes a ton of sense. So if you ask your community and you educate them these things, it's much easier to make these changes. Here was the impact in our system. When we went to a tiered response with a changed response time expectation, we now could deploy BLS units. Notice the change in the number of unit hours that we were able to deploy in our system once we went to a tiered response model in 2021. When we surveyed our ED directors, 11 of them in our community, a year after we started the tiered deployment system, we asked them, hey, so how's the tiered deployment thing going? How are the BLS units that are bringing in these 911 patients, how are they doing? 201, every one of the 11 ER directors said, you did what now? Didn't even notice the difference. Because the patients that needed ALS care got ALS care, the patients that needed BLS care got BLS care. But it reduced our unit hour utilization, it dramatically improved the amount of units that we're able to put out, it dramatically improved our response times to the high acuity calls, because our goal was to improve the response time to the high acuity calls by lengthening the response time to the low acuity calls and heresy holding low acuity calls. Having a waiting room, where's Dr. Kupis, having a waiting room, which is our dispatch queue, that said, hey, we're not going to respond to the alpha level call or the omega level call until we're sure we can get to the echo calls in 9 minutes. And in order to do that, we need level 7. So at level 8, we'll start dispatching alpha level calls. Dramatic improvement in our high acuity response times. It's good that we are nimble, right? And we can change things pretty quickly. Colby mentioned mass trousers, EGTAs. Remember those? Jaw spreaders. Those were awesome, right? Seizure patients open the airway, break their teeth, open their airway using this device, right? Why? Because we got to open the airway. Well, when they're seizing, they're not breathing. What difference does it make? That's what stops the seizure, by the way, in most cases. But we got to change. So Medic in Charlotte now has become the poster child for efficient and effective system redesign with full community support. 1.4 million people, 160,000 911 responses, third service governmental entity, public utility model system, high performance system that they put 55 units on at peak during the day, 30 units on at night. Very, very efficient system. They said, we've looked at our data and you know what? We can reduce our tax subsidy by about $4 million a year if the community would allow us to change response time expectations for the low acuity medical calls to 60 minutes is where they started. October of 21, they did the 60-minute low acuity 911 response time goal. And for the first year, they had 21,000 911 responses with a 60-minute or greater response time. I can tell you, and JP will tell you, that in those 21,000 calls, they got exactly 0 complaints about the response time from the public. They got 3 complaints from the first response agency because it took an hour for the ambulance to get there, to which the medical director for the system said, why were you there? Because you're not even supposed to be there. And our protocol is if you get on a low acuity call and you're not needed, you can leave. So you can be available for the cardiac arrest, because we don't want you hanging out with the ankle pain while a cardiac arrest comes in 2 blocks down. That's counterintuitive to good patient care, good community care. Not one patient complained, because when you call 911 in Charlotte today and you say, yep, I got this sliver in my finger 3 weeks ago and I think it's infected. Call taker says, thank you. Your call is very important to us. We're going to put you into the queue. We're making sure that we can get to the baby not breathing calls pretty quickly. So as soon as we get to a point that we can send someone out to you, we anticipate to have an ambulance at your house within the hour. If anything changes, call us back. So what do they do to that low? They set the expectation that, yep, I called 911, someone's coming. They'll be here about an hour. It's good. Makes time to put the dogs away and all that kind of stuff. The system was so successful in improving the response times to the high acuity calls, and they weren't stacking bodies like Cordwood at City Hall, that this year they're at 90 minutes for those calls. And by the way, they keep reducing their need for tax subsidy because their cost of readiness is dramatically less. Better patient outcomes, no complaints, lower cost, higher utilization of ALS personnel makes total sense. So you'll see some of the outcomes there. Dr. Bronsky didn't mention it because he's very humble, but last year, Colorado Springs Fire Department got a national award from the Congressional Fire Services Institute for the program that Dr. Bronsky talked about. You've got a fire department that's probably one of the most innovative in the country, who gets a national award from the fire service for going to a tiered deployment, changing response times, and everybody in this award, in the Congressional Fire Services Institute, says this is a model system and that more agencies should be doing this as a best practice. So for your city managers, your mayors, look to Colorado Springs, look to MedStar, look to Charlotte. These innovative EMS systems are changing delivery, improving patient outcomes, improving response times to the calls that matter, and reducing tax subsidy as good public policy. This was a national survey post-COVID, kind of showed that, hey, the economic crisis, the staffing crisis has caused systems across the country to change from ALS to tiered deployment, because we don't need a paramedic on every call, because most of the calls are BLS. Lengthening response times, using alternate response models like they're doing in Colorado Springs, like we're doing in Fort Worth, other places. This is the reality. Many of you may know that AIM-HI, the Academy of International Mobile Healthcare Integration, the public utility model high performance systems, put out these surveys and studies periodically. You'll note that in 2022, 36% of the highest performing EMS systems in the country changed from all ALS to tiered response. 36%. In 2024, all of them had changed. Every one of them. Because it's a best practice. And you can staff much differently. You'll see some of the response time guidelines that are present in these communities. Notice that Pinellas County and Pro up in Cambridge, low acuity 911 response time, there is no standard. Get there when you get there. Focus on the high acuity ALS calls, because the low acuity BLS calls really doesn't matter. One of the outcroppings of what we did at MedStar a couple years ago is we looked at this transport ratio, much to what Dr. Bronsky and others have done. And these response determinants changed how we respond. Those response determinants don't get an automatic ambulance response anymore because the transport ratio is very low. And if we're not needed for those calls, let's not go. If the first responders get there, if one of our fly cars get there and they need a bus, call for the bus. If not, we're not going. Just recently, how many people went to Eagles this year? Dr. Peirce, one of the medical directors that's part of the Eagles Coalition, he is the medical director for Houston Fire. He's also the public health authority for the city of Houston. Gave a great presentation, and he said when they went to a tiered deployment system, every metric in their system got better. Response times, call processing times, IV initiation, intubation success rate, you name it, every metric got better when they went to a tiered deployment system. One of his studies from 2007 is in this slide deck that you'll see when you get it. When they went to a tiered deployment system many years ago, their cardiac arrest survival rate nearly doubled because the paramedics were much better at managing cardiac arrest because they were doing it more often. Back in 1980, when I first became a paramedic, everybody laughed at the state of New Jersey because in New Jersey, the state requires that paramedics not be employed by fire departments or EMS agencies. They have to be hospital-based. And you can only provide ALS anywhere in the state using a fly car echo unit model. And we all said that's ridiculous in the 1980s because that's just makes no sense at all. You gotta have a paramedic in every unit, blah, blah, blah. Today, we're all looking at that system saying, man, they were brilliant. Absolutely brilliant, because being hospital-based, they get to be paramedics in the ER when they're not on a call. And they only go on the high acuity calls, and when they go, they're being utilized. So they are phenomenal paramedics because they're using their craft every single day. Makes a ton of sense. We have created this problem. We in this room have created this insustainability of the EMS system by requiring all ALS, by having paramedics on every call, by having artificially inflated value of response times, which drives up huge costs with no clinical benefit. It's up to us to change that if we want these systems to survive. So take-home messages, we have to drive that change, community education. Somebody mentioned it yesterday during dinner. Do it slowly, do it logically, involve the public and involve the community in those decisions, all the agencies, et cetera. But we got to change the expectations. We have given the country the wrong expectation of what we do. You know, years ago during this conference, I asked the room, what percentage of our 911 calls are truly life-threatening, and we got answers of 20, 30%. I bet if we were asked that today, because people have been looking at it, they're going to be realistic and say it's about 5 to 6%. Then why do we respond to 100% of the calls the same way when we know it's dangerous and it doesn't matter? If you haven't seen it, there's a link that you'll get to in the handout that's a recording of this webinar that we did a few months ago with representation from all sorts of different sectors. It was actually co-hosted by AIM-HI and ICMA. One of the great things about this webinar is about half of the attendees were public policy people. And ICMA is now pushing this message out to their members. In fact, I'll be at their annual meeting in April doing a half-day workshop on this issue and the questions they should be asking about their EMS performance and the cost of their EMS delivery and all sorts of different things, especially in, now I won't even go down the GEMT road, that's a whole other discussion. So, if we're riding a dead horse, here are some things we can do. Buy a stronger whip, appoint a committee to study the horse, say things like, this is the way we've always ridden the horse. We can change riders. We can arrange to visit other sites to see how they deal with the dead horses. We can create a training session to increase the ability to ride dead horses. We can harness several dead horses together for increased speed. We can have the chief declare no horse is too dead to beat. We can form quality circles, defined uses for dead horses, and we can then promote the dead horse to supervisor. I would argue that the best strategy when riding a dead horse, dismount. Find another horse. Because the horse we're riding is dead. We just haven't realized it yet.